Good afternoon and welcome to today's webinar, Gestational Diabetes, Pathophysiology, Risk and Outcomes. I am Lisa Dunay and I'll be your moderator for today's event. This webinar is part of the Healthy Mother, Healthy Baby Thought Leadership Series supported by a generous grant from Siemens Healthineers. AACC has partnered with Siemens Healthineers to bring you this webinar series, which will continue throughout 2019. As a global leader in medical technology, Siemens Healthineers is a trusted partner focused on the unique journey from preconception to pregnancy through neonatal care, delivering the clinical tools essential for healthy mother and healthy baby outcomes. This program is accredited for Accent Continuing Education credit. Please note that since this is a pre-recorded webinar, it can be stopped or paused at any time. To get started, make sure your speakers are on and turned up. So again, we thank you for joining us in today's Siemens Healthineers Thought Leadership webinar, Gestational Diabetes, Pathophysiology, Risk and Outcomes. Our speaker is Dr. Jeannie Ray McManus, who is the medical officer for Siemens Healthineers. She received her PhD in genetics from the University of Georgia, and she is board certified in clinical chemistry. Her past clinical research interests include hemoglobin A1C, diabetes, and the development and implementation of mass spectrometry methods in the clinical laboratory. Dr. Ray McManus, you may now begin your presentation.
Okay, thank you for that introduction, and I also just want to say thank you for the opportunity to present today on the topic of diabetes with a focus on gestational diabetes. So given that each of my pregnancies were impacted by gestational diabetes, this is a topic that I have special interest in. So what I hope that you walk away with today, learning objectives are outlined here. So I hope that you walk away with an understanding of the different categories of diabetes. So we'll go over three, type 1, type 2, and gestational diabetes, with an understanding of the pathophysiology of gestational diabetes. Also, understanding what the current American Diabetes Association guidelines are for the diagnosis of gestational diabetes. And finally, being able to describe the recommended lifetime follow-up care for women who have had a history of gestational diabetes. So I just want to start out kind of laying the foundation regarding the importance of diabetes. So diabetes can really be considered an epidemic. Worldwide in 2017, there were approximately 425 million people between the ages of 20 and 79 that were affected by diabetes. And this number is expected to continue to increase by approximately 48% to 629 million people by 2045 being impacted by diabetes. So as you can see in the graph on the right, the increase that's expected isn't due to one particular country, but really it's a disease that does and will continue to impact countries across the globe. So you can see the Africa region on the far left of the graph. There's expected to be about 156% increase by 2045. And then if you look at the Western Pacific region, it's a much smaller increase of about 15%. But overall, you can see the trend across all regions represented here as being an increase. So diabetes and its associated complications are the major causes of death in many countries. In the U.S. alone, diabetes was listed by the CDC as the 7th leading cause of death. And the IDF has estimated that approximately 5 million people between the ages of 20 and 79 years old died from diabetes in 2015. And so if you think of that in deaths per second, that's one death every 6 seconds due to diabetes and its associated complications. So not only is there a human cost to diabetes, but there's also a significant financial cost to diabetes. So this graph kind of sums up some of the different costs by regions. And if we look at the U.S., it was estimated the total economic cost of diabetes to be about $377 billion, with the majority of costs attributed to direct medical costs and a subset attributed to lost productivity. And so if you look at that number, the U.S. saw an inflation-adjusted total economic burden increase of about 25% from 2012 to 2017, which is substantial. And costs related to diabetes continue to grow worldwide. And that leads to economic burdens not only for individuals and families, but also on national health systems. So now that I've told you why diabetes is important, I just want to make sure that we all understand what diabetes is before we move forward. So it's a condition that's characterized by elevated glucose levels, often referred to as hyperglycemia. And these elevated levels of glucose may be due to defects in insulin production by the pancreas. They can be due to defects in insulin action. So for example, a scenario where the pancreas is making insulin, but it's not working as it should, or it could be a combination of both. So glucose is the primary source of energy for the body, and this figure here represents the primary tissues of glucose uptake. The brain is the most important and demanding organ that requires glucose in order to perform jobs such as thinking, learning, and remembering. If you have low blood glucose levels, that can result in the impaired functioning of the central nervous system, and it could lead to symptoms such as dizziness, speech problems, memory problems, irritability, or even loss of consciousness. Glucose that is not immediately needed for energy can be taken up and stored for later use by the liver and muscle cells, and it's stored as glycogen. And once those tissues are saturated with glycogen, the remaining excess glucose that's not needed for energy is converted to fat, and it's stored as adipose tissue. So maintaining glucose homeostasis is controlled by a number of different hormones. The two that you're most familiar with are insulin and glucagon. So insulin is shown here, and it's produced by the beta cells of the pancreas as an inactive precursor. So if you look at the far left top figure, you can see the proinsulin molecule. It has an alpha chain, a beta chain, and the C peptide in red. And so what happens is there's a promoter convertase that comes in. It cleaves off the C peptide to release the insulin monomer, which is the figure down at the bottom on the left. So the main action of insulin is to stimulate the uptake of glucose from circulation for storage in the liver and other tissues. As a counterbalance to that is glucagon. And so glucagon is secreted by pancreatic alpha cells, and it ensures the release of glucose from the liver when blood glucose is low during periods of fasting or exercise. And it's really the balance and interplay between insulin and glucagon that provide the necessary tight regulation of blood glucose levels in normal people. So I've mentioned the pancreas several times in previous slides, and I just want to make sure everybody's oriented to where the pancreas sits. So on the left, you can see a figure with the lungs, the liver, the intestines, and you see a red circle. That's where the pancreas would sit behind the stomach. And so it's an organ that consists of a group of specialized cells that make and secrete hormones, and those groups of cells are known as the islet of Langerhans. You can see the black dot pointing to each of a group of cells. So each of those little island of cells would be known as the islet of Langerhans. Each islet is made up of 5 different types of cells, and those include alpha cells that secrete glucagon to raise blood glucose, as well as the beta cells that secrete insulin to lower blood glucose. So this next figure demonstrates what normally happens after, for example, you eat a meal rich in carbohydrates, and that glucose is absorbed from the gut into the bloodstream, causing glucose levels to rise. So the blue hexagons that you see in the figure are representative of glucose. The light blue helical structures, that's the insulin molecule. And then the yellow cells that are enveloping, those are the beta cells that are responsible for producing insulin. So you can see from this figure there's a fair amount of glucose present in circulation, and so that's stimulates the beta cells of the pancreas to release insulin, and you can see that there's insulin in circulation. And then what happens is that insulin binds the insulin receptor, inducing a conformational change in an entire cascade of signals that ultimately recruit the glucose transporter to the cell membrane. So the glucose transporter are those orange helical structures that you see now sitting in the cell membrane. And then with those transporters in place, glucose can now move down the concentration gradient from the bloodstream into the cell, thereby lowering blood sugar levels. So there's three categories of diabetes mellitus that I want to talk about. Those include type 1, type 2, and gestational diabetes. So we'll start out with type 1 diabetes, which accounts for approximately 5 to 10% of the cases of diabetes mellitus and typically presents in childhood. It's a chronic condition, and there's currently no cure available. The exact cause of type 1 diabetes is not known, but it's thought that there's both genetic and environmental factors that appear to play a role. It's known that people who have a family history or have a close relative with type 1 diabetes, that they themselves are at greater risk for developing diabetes, so that's where the genetic component comes in. For type 1A diabetes, that disease is the result of autoimmune destruction of the beta cell and the islets of Langerhans, while type 1B diabetes is related to islet destruction as a result of non-autoimmune causes. So in the next few slides, I'm going to focus on type 1A, which is autoimmune destruction. So this is just a figure representing the pathophysiology of type 1 diabetes and beta cell destruction by an individual's own immune system. So again, the structure to the left is the pancreas, and the islet of Langerhans represented by the clusters of cells, with the yellow cells representing the beta cells. And the large light blue structures represent T cells that, due to currently unidentified triggers that could be environmental, it could be viral, those T cells are mistakenly programmed to target and destroy the beta cells. So on the next slide, you'll see that those beta cells are now gone from the pancreas. So this process can take years to happen to destroy the beta cells to a level where there is insufficient insulin. And so just again, note the lack of beta cells in the pancreas, and then you'll see that there's no insulin present in circulation. And without that insulin, the insulin receptor is therefore unable to undergo its conformational change and recruit the glucose transporter to the cell membrane. And as a result, excess glucose builds up in the bloodstream, and it leads to a hyperglycemic state. So for type 2 diabetes, it's also characterized by hyperglycemia, but this is an acquired metabolic disorder, and it accounts for about 90 to 95% of diabetes cases in developed countries. It can manifest in one of two ways, either by insufficient insulin production or due to insulin resistance. And while there's no cure for type 2 diabetes, it's known that lifestyle changes such as losing weight or eating well-balanced meals, increased exercise, all of those are crucial to managing the disease, and in some cases they're actually sufficient to reverse the course of the disease. The mechanism by which type 2 diabetes develops is unknown, but there are several hypotheses that have been proposed. The factors such as obesity, aging, beta cell dysfunction, tissue inflammation, and physical inactivity are some of the most common factors that are linked to insulin resistance. And it's that insulin resistance that ultimately progresses to type 2 diabetes. So this figure here that we're looking at is showing insulin resistance. Again, the yellow cells represent the insulin-producing beta cells, and the dark blue hexagons are glucose. And so you can see there's elevated glucose again present, causing the release of insulin. And on the figure on the right, you can see that there's two insulin receptors. One is the insulin receptor to the left, which is functioning normally. Insulin is bound, it's undergone its conformational change and recruited that glucose transporter to the cell membrane, allowing glucose in to the cell. But the insulin receptor on the right You can see insulin has tried to bind, but that receptor has not responded appropriately, and the transporters have not been recruited. So there's diminished capacity for this tissue to take up glucose. And that defect in the insulin receptor, it can either occur at the actual binding level of insulin to the receptor, or it can occur at any point down in the downstream signal cascade that's required to get that glucose transporter to the cell membrane. And as this glucose continues to build up in the bloodstream, it also has a cyclical effect of causing the beta cells to want to produce more insulin. And so that's where we move into transitioning from insulin resistance into development of type 2 diabetes. So in this figure, it's just showing increased glucose present in circulation causes insulin levels to be increased within the beta cell. And that increased excess insulin subsequently triggers beta cells to self-destruct by releasing the chemokines CCL2 and CXCL1. And so these chemokines can recruit a specific type of inflammatory macrophage to the pancreatic islets. These macrophages produce IL-1 beta, which can then trigger the dysfunction of the beta cell and consequently decrease insulin production, which is what this figure is demonstrating. So if your beta cell dysfunction increases and your insulin production decreases, the ability of the body to regulate glucose levels also decreases, leading to a hyperglycemic state and the development of type 2 diabetes. So that's represented in the figure on the right. If you look at blood glucose is represented by the red line. It's increasing over time, consistent with beta and increase in beta cell dysfunction. And you see insulin is decreasing. And so it's really, the inability of insulin to control the uptake of glucose from the circulation that leads to this hyperglycemic state and the development of type 2 diabetes. So how is a person diagnosed with diabetes? Well, diabetes is generally diagnosed based on either plasma glucose criteria or on hemoglobin A1C criteria. What I'm showing here is the American Diabetes Association, or the ADA criteria for the diagnosis of diabetes. You can see that several possible findings may be used to determine if somebody has diabetes. It's either based on a fasting plasma glucose of greater than 126 mg per deciliter. There's also glucose in a non-fasting state following an oral glucose tolerance test, or there's hemoglobin A1C criteria. And what's important to note for these first three criteria is that in the absence of clear clinical diagnosis of diabetes, such as a patient presenting in a hyperglycemic crisis or with classic symptoms of hyperglycemia and a random plasma glucose of greater than 200 mg per deciliter, the diagnosis requires two abnormal test results, either from two separate test samples or, new to this year's ADA guidance document, those two abnormal tests can actually come now from the same sample. So for example, if you had a patient that came in, they had an elevated fasting plasma glucose, it was greater than 126, and you had another sample available that you can measure A1C on, you can measure A1C, and if it's also elevated, you could diagnose that person with diabetes. So on the previous slide, we mentioned both plasma glucose and hemoglobin A1C as assays that can be used to diagnose diabetes. These tests can also be used to monitor diabetes as well with different purposes. So for glucose, the sample can either be fasting or non-fasting. And with glucose, it represents a single point in time relative to the glycemic state of the patient. And this is in contrast to hemoglobin A1C. So hemoglobin A1C is a molecule that's glycated at the N-terminal of the beta subunits. It's a non-fasting draw, and it represents average glycemia over the preceding 2 to 3 months. So it gives you a better picture of what's happening with those average glucose measurements over a longer period of time. And while it's not recommended for diagnosis, there may be instances, for example, where hemoglobin A1C test is not sufficient for determining average glucose levels. And so in those cases, fructosamine could be used to look at long-term glycemic control. So conditions that I'm referring to that affect red blood cell turnover, maybe things like pregnancy or certain hemoglobinopathies. So in those cases, you can measure fructosamine, and those values provide an alternative to hemoglobin A1C, but it just provides glycemic information for the preceding 2 to 3 weeks versus 2 to 3 months. And it should also be noted that the prognostic significance of fructosamine values are not as well established as they are for hemoglobin A1C. So I've mentioned hemoglobin A1C several times. I just want to stop really quick and make sure that everyone understands what hemoglobin A1C is. So hemoglobin A1C is a measure of how much hemoglobin is in the form of hemoglobin A1C. So why do we care about hemoglobin A1C? Well, hemoglobin A0 is composed of 2 alpha and 2 beta chains, and so that's represented in these figures. Each of these molecules that you see of the 3 are a hemoglobin molecule. And in the presence of glucose, hemoglobin A is glycated to form several different species, including hemoglobin A1C. So hemoglobin A1C represents a non-enzymatic addition of glucose to the amino terminal valine residues at the hemoglobin A beta chains. And so you see, again, the blue hexagons, those are representative of glucose, and then, the glycation of hemoglobin A to make hemoglobin A1C. The formation of hemoglobin A1C is irreversible, and it forms at a slow rate as a post-translational modification throughout the lifespan of the red blood cell. And several studies have established a direct relationship between hemoglobin A1C, average blood glucose concentrations, and the onset and progression of diabetic complications, as you'll see in the next slide. So the US-based NGSP recommends reporting hemoglobin A1C values as a percentage, while the IFCC recommends reporting hemoglobin A1C in millimoles per mole. So here what's being shown is that as hemoglobin A1C values and coinciding average glucose levels rise, so too does the risk for developing diabetic complications. So each of the different colored lines represents a different hemoglobin A1C value. So for example, the red line represents a hemoglobin A1C of 11%, and you can see there's an increased rate of diabetic complications if you compare it to the green line that represents a hemoglobin A1C of 7%. So these goals for the recommendation for most non-pregnant adults is achieving hemoglobin A1C of 7%. All right, so because hemoglobin A1C values are correlated to the development of diabetic complications, the DCC and the UK-PDS trials that established the treatment goals of 7% also stressed the importance of providing accurate and precise hemoglobin A1C values. So since then, hemoglobin A1C values have been standardized to the DCC p-values in most of the world. The NGSP and the IFCC groups have also worked with manufacturers to improve the performance of hemoglobin A1C methods. And then in addition, the College of American Pathologists began using accuracy-based surveys based on target values set by the NGSP beginning in 2007. So instead of using peer group means, everything is accuracy-based. And if you look at the acceptability criteria as a percent of target, you'll notice that over time these criteria have tightened. So in 2007, it was plus or minus 15%. Today, it's plus or minus 6%, and it's expected that criteria will be tightened to plus or minus 5% in the coming year, just reflecting the acknowledgement and importance of providing accurate hemoglobin A1C results for patients. So this is just a summary of some of the long-term potential consequences of uncontrolled or poorly controlled diabetes. So while glucose is an important source of energy for the body at sustained elevated levels, it's also toxic to cells. and therefore can have damaging consequences. So for example, damage to the nerves can cause neuropathy that can affect different parts of the body, but most commonly impacts the hands and the feet. And so that's represented by the person on the far left. You can see red shading in the hands and the feet to represent that neuropathy. Damage to the vascular system can also lead to skin ulcerations. So in the second figure on the leg, you'll notice that there's a yellow and orange spot. So that's representative of a skin ulceration. And because of the loss of sensation in diabetics due to neuropathy, they may not be aware of the seriousness of injuries that they have, and those injuries may become infected and necrotic and consequently require amputation. And so that's why the second figure on the left is missing a leg, just representing amputation. Vascular disease can also cause hypertension and organ damage, such as retinopathy that can lead to blindness. It can also result in kidney disease, heart disease, early cognitive impairment, and stroke. So you can see why it's important for someone who has diabetes to make sure that they're maintaining their glycemic targets. So the last category of diabetes is gestational diabetes. So gestational diabetes is often described as a temporary type of diabetes. It generally resolves after delivery. It occurs in approximately 14% of all pregnancies and is one of the most common health problems for pregnant women. One of the important things to note is that having gestational diabetes increases a woman's lifetime risk of developing type 2 diabetes later in life. So how does gestational diabetes develop? We'll start just by talking about that during pregnancy, the placenta makes hormones that are necessary to support implantation and early embryo growth. The placental secretion of so-called diabetogenic hormones can include growth hormone, corticotropic releasing hormone, prolactin, and progesterone. And all of those can act to lead to a normal, mild insulin resistance during the first trimester of pregnancy. And that's again depicted by that black insulin receptor on the far right of the screen in that cell membrane that you see. So we have glucose present, and those hormones that are produced by the placenta impair the ability of the mother's own body to take up glucose. And what happens then is that this reduced uptake of glucose by the mother's own tissues creates greater availability of glucose in the blood that can support the rapid growth of the developing fetus. So that's represented in the top left, the extra glucose you can see now around that embryo. So in response to the increased plasma glucose, the beta cells of the pancreas increase insulin production and release, and that results in a mild hyperinsulinemia state for the mother. So now you can see those beta cells in this figure are producing more insulin. And so the precise mechanism for how gestational diabetes develops is unknown. It's known that it's more likely to develop in overweight or obese women, and that suggests, again, the potential of inflammatory cytokine release from excess pre-pregnancy adipose tissue are responsible for damaging insulin receptor signaling. Hyperglycemia develops due to the combined effects of existing insulin resistance and also the pregnancy hormone insulin resistance that's normal. And the compounding of those two can result in increased insulin production by the pancreatic beta cells. And so in gestational diabetes, it's believed that the beta cells continue to produce insulin in an attempt to compensate for the excess glucose. And instead of insulin suppression caused by cytokine-induced cellular dysfunction, like we talked about in type 2 diabetes, the energy that's needed for insulin production actually outpaces the energy that's available to the beta cells, and those beta cells then become exhausted. And that beta cell exhaustion then results in reduced insulin production and subsequently, reduced ability of the mother's own cells to take up glucose. So here, just showing beta cell exhaustion, now you can see that those beta cells on the left are not producing as much insulin. So there's not as much insulin to act on those insulin receptors to uptake that glucose. And so as glucose levels continue to rise, more and more beta cells become exhausted, and that results in less and less insulin that's present, and it just leads to a vicious cycle that eventually manifests as gestational diabetes. So the prevalence of gestational diabetes varies worldwide and is reflected here, showing different regions, age-adjusted prevalence, and the number of live births affected. Oh, sorry, I'm on the wrong slide. Actually, it's estimated by the IDS that 21.3 million or 16.2% of live births to women in 2017 had some form of hyperglycemia in pregnancy. So if you just look at this table here, you can see that the global prevalence is 16.2%. The proportion of cases due to gestational diabetes mellitus is estimated to be approximately 86.4%. The proportion of cases due to other types of diabetes that are first detected in pregnancy is estimated to be 7.4%, and that can include type 1 and type 2, and then the 6.2% represents cases where diabetes was detected prior to pregnancy. And so this was the figure I was referring to for the prevalence of gestational diabetes worldwide. And so if you look at some of the different regions and the age-adjusted prevalence, for example, Southeast Asia, their age-adjusted prevalence for gestational diabetes is 26.6%. In Africa, it's about 9.5%. And then in the North America region falls somewhere in the middle, around 12%. So one of the risk factors for gestational diabetes is age, and that's reflected in the graph on the right by the rapidly increasing prevalence of hyperglycemia with increasing age. So as you move up in age, you can see the prevalence of hyperglycemia in pregnancy increases. And just of note, nearly 50% of all cases of hyperglycemia do occur in women under the age of 30, but that's really more of a function of their increased fertility. So just important to take away from this slide is that as age increases, the risk of developing gestational diabetes also increases. So other risk factors for gestational diabetes are summarized here. So similar to type 2 diabetes, gestational diabetes is largely linked to pre-existing conditions of overweight and obesity, as well as metabolic syndrome and PCOS. So if a woman has had gestational diabetes in a previous pregnancy, if she's had a previous stillbirth or a miscarriage or a macrosomic baby weighing greater than 9 pounds, she is also considered to be at increased risk of developing gestational diabetes. And race and ethnicity may also play a role in the susceptibility for developing gestational diabetes, as illustrated by the graph on the right. You can see Asian Americans, the rate of gestational diabetes is almost 10%, while in African Americans it's about 4%. So it's important to be aware that 2 generations are at risk when gestational diabetes is present. It's not just the mother that's at risk, but it's also the fetus. For the mother, complications such as preeclampsia that can develop into eclampsia, that's characterized by dangerously elevated blood pressure, can develop, and that can lead to fetal and or maternal death. Mothers with gestational diabetes are also at increased risk of developing insulin-resistant type 2 diabetes later in life, as we've mentioned before. For the fetus, complications of gestational diabetes include excessive growth due to abnormally high levels of glucose crossing the placenta. And so that excessive fetal growth can result in a baby that's difficult to deliver, and in some cases that may require a cesarean delivery, which has its own set of potential risks. Hyperinsulinemia can also develop in the fetus as a consequence of maternal hyperglycemia. So if you think of a situation where the mother is unable to control glucose levels present in the bloodstream, that excess glucose is crossing over into the fetus, and then in response, the fetus has to make insulin to regulate its own blood glucose level, and so therefore that's this hyperinsulinemia state. And what can happen is that when that source of glucose from the mother is removed at birth, a neonatal hypoglycemia can occur, just because now the baby has all of this excess insulin that's present, and there's not, that excess glucose present from the mother that needs to be taken up. And so therefore, neonatal hypoglycemia, and that may trigger, some additional care either in the NICU or just additional follow-up that needs to happen after delivery. Children born to mothers with gestational diabetes themselves are also at increased risk of childhood obesity, as well as developing type 2 diabetes later in life. So because of all of these consequences, potential risks of diabetes and pregnancy, it's very important for all women of childbearing age with diabetes to seek preconception counseling before becoming pregnant. And the goal of that preconception counseling is to really establish a hemoglobin A1C that's less than 6.5%. And that number, that target is chosen because it's the number that's associated with the lowest risk of congenital anomalies. So women with pre-existing diabetes, when they go for their preconception visits, those visits should include diabetes-specific testing, such as hemoglobin A1C, a thyroid-stimulating hormone, creatinine, and urinary albumin to creatinine ratio. The key components of preconception diabetes management include glycemic control, so just making sure that the mother is able to, has her diabetes under control and maintain certain targets, to ensure that she's proficient at diabetes self-care, and also the medical optimization of pre-existing complications and comorbidities associated with diabetes. So really just ensuring that the diabetic mother is as healthy as she can be prior to conceiving. The IDS also recommends that women who have had gestational diabetes in a previous pregnancy also seek preconception advice from a healthcare professional. And in situations where a woman who has diabetes that is not well controlled, she may be advised to allow a minimum of 6 months or so to achieve that optimal control before trying to conceive. And that's, again, to reduce the risk of congenital anomalies. So how do you diagnose gestational diabetes? There are two approaches. There's the one-step strategy and the two-step strategy. So I'll start by describing the one-step strategy here. It's performed at 24 to 28 weeks gestation in women who are not previously diagnosed with diabetes. So in this strategy, the mother would arrive at a testing site following an overnight fast of at least 8 hours. An initial sample would be drawn for a fasting plasma glucose, and then she would consume a drink containing 75 grams of glucose, and then subsequent samples for plasma glucose would be drawn at 1 and 2 hours. And the diagnosis of gestational diabetes is made when any of the following criteria listed here in the bottom left are met. So fasting of 92 mg per deciliter or greater, 1 hour of 180 mg per deciliter or greater, or 2 hour of 153 mg per deciliter or greater. So in the two-step strategy, this is also performed at 24 to 28 weeks gestation in women who are not previously diagnosed with diabetes. In the first step, a 50-gram glucose drink is given to a non-fasting woman with a plasma glucose measurement at 1 hour post-consumption. And so if that plasma glucose measured at 1 hour exceeds any one of these three cutoffs, which the specific cutoff chosen by the physician can be made based on the sensitivity and specificity they're looking for. That's why there's 3 different criteria here. So depending on which criteria the physician's office is using, if any one of these values are met or exceeded, they would proceed to step 2. So in step 2, it consists of fasting 100-gram oral glucose tolerance test. So you have plasma glucose measurements also at 1 hour, 2 hour, and 3 hour. And the diagnosis is made if at least 2 of the 4 plasma glucose measurements in this table are met or exceeded. The goal of treating diabetes is really to keep blood glucose in a normal target range in order to reduce the risk of complications from gestational diabetes. Glycemic targets during pregnancy can include targets for fasting and either 1 hour or 2 hour postprandial, so after eating a meal. And those criteria are listed here on the far left. Hemoglobin A1C can be used as a secondary measure of glycemic control, with levels less than 6% in the second and third trimesters associated with the lowest risks, but what's generally used are glucose measurements. So there's two main approaches to treating gestational diabetes, and these include lifestyle management and/or pharmacologic therapy. So with lifestyle management, that includes adhering to an individualized nutritional plan. So you would go in, or the female would go in, meet with a nutritionist that would establish a plan for meals and snacks that consist of a certain amount of carbohydrates and protein to really help target those glycemic goals. Physical activity would likely also be recommended, especially post-meal, to help with glucose metabolism. If appropriate, weight management program could be instituted with the patient as well. And what's important to know is that studies suggest that lifestyle modification alone is sufficient to control gestational diabetes in about 70 to 85% of diagnosed women. If lifestyle management is not sufficient, then pharmacologic therapy may be needed. And so options for those include sulfonylureas such as glyburide, metformin, or even insulin to help maintain those glycemic targets and reduce the risks associated with gestational diabetes. So while in many cases gestational diabetes resolves following delivery, appropriate postpartum follow-up is important to ensure that the gestational diabetes does not represent pre-existing undiagnosed type 2 diabetes. So the appropriate follow-up care includes fasting glucose that's monitored 24 to 72 hours after delivery to check for overt diabetes. And that's defined as a fasting glucose greater than or equal to 126 mg per deciliter. And then there's also a recommendation by the ADA test for persistent diabetes 4 to 12 weeks postpartum with the 75-gram oral glucose tolerance test. So in scenarios, because gestational diabetes is associated with an increased lifetime risk of maternal diabetes, if the fasting glucose, post-delivery was normal and that 75-gram OGTT was normal, then the recommendation is to test women who have had gestational diabetes every 1 to 3 years with any of the approved glycemic tests, which includes the plasma glucose test we talked about earlier and or hemoglobin A1C. So just in summary, it's important to note that the worldwide prevalence of gestational diabetes is approximately 14%. It's known that gestational diabetes is associated with increased risk to both the mother and the fetus, and those risks include preeclampsia, macrosomia, and potential cesarean delivery. Early screening and diagnosis is important in the appropriate management of gestational diabetes in order to reduce some of the pregnancy complications and adverse neonatal outcomes. And then the increased lifetime risk for women with a history of gestational diabetes really necessitates that there's appropriate follow-up, not only during the postpartum period, but beyond. And with that, I'd just like to thank you again for this opportunity to present.
Thank you, Dr. Ray McManus, for presenting that excellent presentation. So we're now going to begin the pre-recorded Q&A session, which includes some questions that were previously submitted. So the first question is, can the development of gestational diabetes be avoided? Okay, that's a good question. However, because gestational diabetes can occur in women who are apparently healthy and who do not appear to have significant risk factors for gestational diabetes, it's often difficult to identify those women who are at risk and be able to take preventative action. So we talked about
different risk factors that could lead to gestational diabetes, but it doesn't necessarily mean that you have those when you develop gestational diabetes. However, factors that are known to contribute to the development of gestational diabetes, such as being older or being overweight, or even gaining excessive weight during pregnancy, those type of factors can be addressed either prior to conception, if it's a recommendation to lose weight prior to conceiving, or even during the pregnancy, again, that weight management plan to ensure that you're not gaining excessive weight. So hopefully addressing all of those different factors can reduce the chances of gestational diabetes mellitus, but there's no way to really identify who is known, that will develop it and then prevent it.
The next question is additional or special prenatal care required for pregnant women with diabetes?
So there is some special care that may be required for pregnant women with diabetes, and the extent of that additional care can depend on how well controlled the glucose levels are in the female. So special care can come in the form of nutrition counseling. So if someone is diagnosed with gestational diabetes, they'll likely be referred to a nutritionist to help develop that plan, the eating plan that's appropriate to their situation to maintain glucose levels. You may check in with that nutritionist at several points along the way to see if there needs to be modifications to that meal plan. Women would also be checking their glucose levels regularly, so fasting and then after meals. So you would check in with your doctor or a nurse on a regular basis to make sure that those glucose levels are staying within target. There may also be some additional antenatal testing, just checking the growth of the baby, making sure that there's not excessive fluid buildup. And there's likely to be an assessment of fetal growth at about 36 to 39 weeks to estimate fetal weight in women with gestational diabetes to really assess, is there a need potentially for a cesarean delivery. So those are kind of some of the examples of the additional care that may be needed in women with gestational diabetes.
The next question is, would you say there's an advantage of using either the one-step or two-step strategy for diagnosing gestational diabetes?
Again, this is a good question, and it's one that doesn't have a simple answer, given that there's not a consensus from the experts for how best to screen for gestational diabetes. So in the U.S., we generally follow a two-step strategy, and the cutoffs in that two-step strategy that we looked at in the presentation were set by defining those women who are at increased risk of developing diabetes after pregnancy. And so, in addition, there was also a concern regarding laboratory errors that might lead to the misclassification of pregnant women as having gestational diabetes. So it was thought that having a requirement of 2 or more abnormal test results could potentially mitigate that risk. So that's really kind of where the two-step strategy came into play. The International Association of Diabetes and Pregnancy Study Groups recommended the diagnostic criteria we reviewed for the one-step strategy. And the ADA has accepted these diagnostic criteria, given that they're the only ones thus far that have been based on pregnancy outcomes rather than endpoints such as the prediction of the development of diabetes. With that, it was known that having just a one-step strategy could potentially significantly increase the incidence of gestational diabetes. It was estimated that it could go from about 6%, potentially up to 20%, due to just using only one abnormal value. But in light of all of that, the one-step approach is the approach that's used by most of the world. So while there's not necessarily a global consensus on which approach to use, there is a global recognition that screening of pregnant women for gestational diabetes is a critical component of prenatal care, whether it's via the one-step strategy or the two-step strategy.
Well, thank you, Dr. Ray McManus. That wraps up the question. So we appreciate your presenting this excellent presentation and answering the question. And would also like to thank all of you in the audience for listening to this Siemens Healthineers Thought Leadership webinar. To claim your Accent Continuing Education credit, you may refer back to the email that you received with the link to this recording, and you will find a separate link for claiming your credit. Now, this recording will also be posted shortly on the Thought Leadership Series webpage on AACC's website. And there you will find an archive of all of the webinars in this series in case you would like to view others that you might have missed. And coming up next month, be sure to mark your calendar for May 15th when we will have the next Healthy Mother, Healthy Baby Thought Leadership Series webinar entitled Thyroid Dysfunction in Pregnancy and Its Effect on Neonates. So again, that will be on May 15th, so please be sure to mark your calendar for that. And that's it for today, so thank you everyone, and we hope you have a wonderful rest of the day.